So we move to the next presentation. And my co-chair.
The second speaker of the opening lecture is Professor Celli. Currently, Dr. Celli is a professor of medicine at our medical school and is the director of the COPD Center at Brigham and Women's Hospital in Boston. Professor Celli is one of the world's leading experts in the area of pulmonary medicine, with a particular emphasis on COPD. Throughout his research career, Professor Celli has become a leading investigator of COPD. He developed two indices to improve COPD clinical care: the BOD index, which helps to evaluate mortality risk in COPD patients, and the COAT index, which measures COPD comorbidity severity. He worked also on biomarkers of COPD using blood or tissue to predict the risk of developing COPD and begin therapies much earlier. Professor Celli is the author of more than 280 peer-reviewed articles, of more than 350 scientific abstracts, and several books related to COPD. Professor Celli research has been published in highly prestigious journals, including the New England Journal of Medicine, CHEST, and so on. Additionally, Prof. Celli has been a passionate educator and mentor to the next generation of doctors and researchers. Now the word is to Professor Celli.
Can you hear me now? Thank you, Dr. Becky, Dr. Roversi, Leo, for inviting me to the land of Ferrari. When I was little, I used to see Ascari and all these guys running these Ferraris, and I was born in Venezuela. It looked so far. And yesterday I went to the museum and I was able to take my picture right next to a Testarossa. I could not drive it. So they asked me to talk about management of chronic multimorbidity, and there is only one disease that I know a little bit about, which is COPD. So I will talk about multimorbidity in the COPD patient. These are my conflict of interest. They do not differ too much from those of Jürgen, except that my wife does not work and never did for any drug company. So what are we going to cover? Well, first is, how does a doctor feel about seeing patients? And I will speak from a personal constraint of being a specialist. The evidence for the care of the patients with multimorbidity. Are multimorbidities just one on top of the other, or are there associated diseases, like you mentioned kidney and COPD, that are favored in a patient that I have in front of me with COPD? I will use a bit of the tools that may look sophisticated just to open the door to see if we can learn a little more about multimorbidity, and then we'll come to some conclusions. So let me start with the experience of a doctor. And for this, I take my hero. And my hero is Dr. William Osler. He wrote the following about a century and a half ago. Variability is the law of life. And as no two faces are alike, no two individuals react alike and behave alike under the abnormal conditions which we know as disease. So no COPD looks like the next COPD. And in order to look into that, I will show two patients. First one is this 44-year-old woman who came to see me on October of 2012 with the history that you see here. Primarily severe shortness of breath, getting so much worse that she could not get off the stretcher, with a boat of 8, a Goldie, and an FEV1 of 0.51 at age 44. And this woman luckily had spirometries, and we should never forget to do some spirometries. Here is the spirometry, the chest CT. Here is the spirometry in 2008, 2010, 2012. She had lost over 300 milliliters of FEV1 in a space of 4 years. We threw everything at her, as it is supposed to be, and this woman needed a transplant. So for me, this is COPD and primarily COPD. At the same time, In a similar week, this woman showed up with those eyes that you cannot take your eyes off if you see her. 14 years of dyspnea, and look at the number of diseases that she had. Hypothyroid, coronary artery disease, hyperlipidemia, diabetes, depression, GERD, osteoporosis, obstructive sleep apnea, obesity, and the disease that nobody wants to see in clinic, fibromyalgia. Everything aches. She's on 18 medications, has again a BOAT of 9, so same stage of COPD, but look at her current FEV1 and compare. Chest CT showed some emphysema, big heart, but I want you to see the FEV1 since 2004 to 2012. This woman had an FEV1 that remained more or less stable through the 8 years that we had FEV1s on. So although she had COPD, COPD was one of many diseases and probably not the one that was causing the major problems. What we did for her was follow her, put her on medications, gave her non-invasive ventilation, and finally she never wanted to be intubated and needed hospice. So one is a patient with acute, severe, disabling COPD, where that is the disease with very little comorbidity. The other one has a lot of multimorbidity. So what is the evidence of what we can do for patients who present with multimorbidity? And unfortunately, here we have a lot of problems. This review of multimorbidity, where they did a meta-analysis of all the studies these people could find, 20,000 potential articles, 10 articles were randomized through 3,000 patients, and they evaluated what effect on multimorbidities had if we created the Taco Bell building or if we changed the clinician's behavior. And to make a long story short, if you want to leave the conferences, this is what I can teach you about multimorbidity. Evidence on the care of patients with multimorbidity is very limited. More research is needed about specific interventions and their impact on outcomes. So when you ask me at the end, what do we do for this, that, and that, I will not be able to present any evidence except the clinical experience of each one of us. So I think we have to turn the page and see what can we learn from multimorbidities or comorbidities. Is a comorbidity of a patient with COPD any disease that a person has, a second, a third, a fourth? Or are there diseases that are grouped around the index case of my patient that I have to think of? If we look at the arithmetic effect, there is more morbidities in patients who have COPD than in controls. This is a study, and there are several, where you can see that patients with COPD had more number of comorbidities than individuals without COPD, and this has been repeated many times. However, much more important is if we can detect diseases on my index case that will influence on the burden of symptoms, on the response to therapy, on the quality of life, on the risk of being admitted, or on mortality. Now, to us, and Jürgen was together with me in this TORCH study, that TORCH study had a virtue. It looked at mortality, and it had a committee that was able to determine what patients died from. And thus the data is very reliable, much more so than writing on the death certificate. In that study, which was 3 years, I was very impressed by the fact that yes, some people died from respiratory diseases, a bunch of them died from cardiac, but I was struck by the fact that lung cancer killed 80% of the 21% of individuals who died from in that cohort. This was repeated in Uplift, and I think we're seeing it again in Summit, indicating that for a trial where we try to select people who do not have cancer, an increased incidence of this particular diagnosis is very attractive to open doors of possibility to look what can we do for that. And to be very honest, because in this meeting there will be a lot of cardiovascular, vascular. I've selected cancer as the index, lung cancer as the index of how we can associate an open door on morbidities. Because of that, and because we have the BOAT cohort formed in 5 countries, we have about 2,500 patients, and we've registered morbidities as we see them every year in clinic, we did the following study that was published by Miguel Divo. What is the prevalence of diseases? 78 diseases were seen, and you see them here in a bar. What do we learn from this? Well, we learn that there are the bad guys. El-Assad, Mugabe, Maduro, Putin, Kim Il-sung, hypertension, renal failure, GERD. How does that help a doctor? I cannot ask 78 questions when a patient comes in. Do you have ingrown toenails? Well, if we look at the way we can handle high throughput data, we can learn from that. And the ability we had to analyze that data, those 78 comorbidities, brought about this, which I think is a fairly informative data set. These are clinic patients with COPD in 5 different countries, and what we have shown here is the prevalence of a comorbidity as the size of a planet, and the association between the planet and death within a circle, this orbit that represents statistically significant outcomes. Now, inside that circle, you see disease, and I will point out lung cancer, but there are others that, even though being cardiovascular, do provide increased risk. Atrial fibrillation, coronary artery, and CHF, where there are diseases that are located very far out, that although highly prevalent, do not carry an increase in mortality. Interesting, all of these 3 diseases have treatment. CPAP, statins or treatment of hyperlipidemia, and even erectile dysfunction. Whereas for many of the diseases in here, we have little that we do as personal therapy. If we then look at the same comorbidome, and I'm going to single out lung cancer, there appears to be an association between having obstructive lung disease and the presence of cancer. We could all say it is due to cigarette smoking, but I will challenge that. I will challenge that based on the following analysis. We took all these patients and now included clinical characteristics, and we performed a network system analysis. And what I'm going to show you here is what happens if you cluster mathematically and unbiased the different diseases, but their strength of their associations. We may find out that diseases may group together with clinical variables, and that may offer insight as to explanations of therapies that could be applied down the road. We just published this paper in the ERJ where we have the system network of the lungs. This is the kind of papers that Jürgen was referring to. Hard to reject once you see that picture. And all I can tell you from this is that there is a lot more comorbidities in patients with COPD here in the right lung than patients without COPD of the same age and everything else being the same. However, if you then question the data and say, I want you to, in this huge map, select me the neighborhoods within that city, the information becomes very interesting. And we detected 9 clusters. This first cluster refers very well to the question that was raised a few seconds ago. These are older individuals who cannot walk very much, who are short of breath, who are thin. What I want you to see is that this city, this neighborhood within the and mathematically questioned, is associated to certain comorbidities: atrial fibrillation, pulmonary hypertension, CHF, and coronary artery disease. So they may be linked pathobiologically. And those differ from the next cluster, which we call cluster 3, where you can see that individuals who are younger, are thinner, have many cancers: esophageal cancer, lung cancer, breast cancer, liver cancer. And at the center of this cluster, you have substance abuse, schizo disorders, or depression. We concentrate on the periphery, but I challenge you that perhaps the treatment for this disorder is at the center, is in the brain, it's earlier, it's addiction. It's not the EGFR receptor. Having said that, how can we hypothesize this works? Well, we could say each one of us is made out of the genes that were given to us by our father and our mother, and we are exposed to an environment, including the microbiota. Our response to that exposure results in a sequence of expressions of cells and metabolic pathways that can be measured. we have the capacity of high throughput measure. If and when our body responds, it can only respond in certain ways. It can only respond by producing inflammation. It can only respond by either thrombosing or hemorrhaging, developing fibrosis, an immune response, cell proliferation, or apoptosis. Now, if we look at our patients, the obese patient, the doctor here was mentioning on the left, all these things have been shown to be more common: inflammation, fibrosis, and enhanced immune response. Whereas the thinner guy has more cell proliferation, apoptosis, necrosis, and senescence. And it is these kind of individuals who will develop lung cancer. And it is these kinds of individuals who become the blue bloater that develop frequent exacerbations and problems of inflammation. So, the last 10 minutes, I'd like to select the disease that we found increased mortality and the disease that was present in cluster 3, which is lung cancer. Now, everybody in this room right now is thinking, well, that's due to the fact that they smoke. They have COPD and they have lung cancer because they smoke. Well, I propose to you that it may not be that easy, and that perhaps it is not just the one who smokes, but is the one who has obstruction that is at risk for cancer. Furthermore, it's not the one that smokes and has obstruction. It is the one that smokes, has obstruction, and emphysema. And therefore, the pathobiology of disease of that group may not be exactly the same of the pathobiology of disease of the one that has obstruction, same degree, but does not have emphysema or smokes. Now, why do I choose lung cancer? I choose lung cancer because if you look at the list of big killers, COPD is right up there, and 2 rows below, lung cancer comes up as number 4. So between the two diseases, we're killing about 300,000 people in the US. That is very close to the deaths that are associated with ischemic heart disease. It is very important to choose lung cancer. Why? Because if you look at the national screening, we say there is little we can do for comorbidities. The national screening trial of CT scans for cancer in 50,000 smokers was able to show a difference in survival between those treated or in patients, in subjects who smoked, who had a CAT scan, versus those that did not. Who are those patients? Well, those patients happen to be the ones that have smoked more, older than 55, and that was the guidelines that perhaps we should follow, which gives you a very low predictive capacity. Not too long ago, Dr. Cosio came up with the idea that perhaps the people who would have lung cancer earlier were individuals who had milder COPD rather than more severe COPD. Based on that, we took the both cohort, and Juan Pablo de Torres published a paper that showed that there was an increased association between lung cancer, COPD by spirometry, that was inverse to what we thought, that it was more prevalent in individuals who had low BMI and milder COPD. Because it is customary when you try to evaluate whether these factors can predict outcome to have a derivative cohort and a validating cohort, we were able to join the group in Pittsburgh and come up with an algorithm that included older age, BMI less than 25, the thin individual, many pack years, and emphysema by CT, and integrated them into a score, linking together those characteristics that we had found were predictive of lung cancer. This is shown here in terms of the area under the curve compared to applying in the same cohort the criteria derived from the lung trial cancer screening program. What you see here is that the area under the curve was much higher, significantly higher, if you chose selected patients and if you applied the lung cancer screening criteria. And we concluded that we can, in our patients with COPD, select specifically for a higher likelihood of having a better yield individuals who are thin, who are older, who have emphysema. I'm not going to show you the data that says that you do not need a CAT scan, that you can substitute the CAT scan with a DLCO that was published in Chest, where the low DLCO, older age, and smoking was a very good predictor of who should be followed with ACT. So what are my conclusions? Multimorbidity and aging are here to stay, and this is exactly what Jürgen had postulated before. Multimorbidities or comorbidities are interconnected, producing an additive that's one on top of the other, but more importantly, a multiplicative effect. We may be able to learn using unbiased statistical methods, clusters, to look at groups. And this would be a screening method to then investigate more deeply those different groups. It could affect management. And I have used lung cancer as the example. More importantly, it could affect investigation. It may very well be that we will cease to have, Jürgen was providing the example of a big building or just Uber. Well, it may very well be that we will not have specialists anymore, that we should train individuals on pathobiology, people who are very good in immune system. So when the therapy arises for diseases that have immune problems in common, several of them together, collagen vascular diseases, for example, you have one group of therapists. If you had the people who deal with the cluster 3 or cluster 1, you would have people specialized in obesity, stem cells. So the specialist becomes not by organ, as it was in Osler's time, but by pathobiology. So I think we're opening doors. I do believe that we will advance and we will be able to tailor therapy to pathobiology that have commonality in diseases once we examine where they're arising from. I think we're just beginning. And just as Jürgen said, I would not embrace the gloom. I would embrace the bright light. I believe we will be able to use this new technology of high throughput and come up with abilities to join diseases together. And I'll go back to William Osler. The reality is that if it were not for the great variability among individuals, medicine might as well be a science and not an art. We're not robots. We're doctors. And we will be seeing patients one by one with either one disease or several diseases. And it is my dream as I get older that the younger individuals will pick up these pieces of science that will allow us to study pathobiology at an ever deeper method that we have not been able to do until so far. So I thank you very much, and I please beg you to forgive me for not giving you specific details except for lung cancer. But there will be plenty of vascular problems afterwards that you'll be listening to, and I'm sure we'll learn from that. Thank you very, very much.
But based on what you said and on your knowledge, would you think that we are ready to recommend screening for lung cancer in patients with severe COPD, low body mass, and high smoking history?
Absolutely. I think the data supports it. Even Medicare in the United States is now paying for lung cancer screening. And those guys do not want to pay for anything. So I do it, and to be very honest, I take the DLCO or the CT that shows emphysema as the people that I would follow with CT scans.
Well, thank you very much. Wouldn't it not make more sense from what you said that lung cancer screening should be done for emphysema and not for COPD? Because
that's a good question.
What you have been alluding to is, if I translate it and break it down from the solar system and the confusograms from the ERJ to a clinical message, and that is, emphysema is not COPD, is not chronic bronchitis, and if you look for a specific cluster for lung cancer risk, it is the emphysematous patient that is light. So couldn't you imagine that you would enrich the population as risk factors, not by smokers, but by people with a low BMI and signs of emphysema?
Absolutely. Absolutely. The data on emphysema is very strong. It's been shown in our cohort, in the Pittsburgh cohort, and I think it's very solid. What happens is a lot of people don't have CTs, and a poor men's CT would be a DLCO lower than 80% predicted. So if you had COPD or a low DLCO and you had a lower BMI, you had a long history of smoking, that would be a good surrogate marker.
Well, partly the reason why I'm saying this is because the data are emerging that obviously emphysema is a very different entity, also in terms of comorbidities. And I think we are probably at a loss when we postulate that COPD as such has such a great array of comorbidities, because the input signals COPD as such is already so heterogeneous that you will multiply the opportunities for comorbid diseases. I think if you would restrict it to a pathomechanism that is not an umbrella terming this, which is much too broad and probably is a very diverse entity, maybe the clusters would be smaller.
Well, I did not show you a full data set of all our patients and the 4 cluster studies that have been done, including one in Eclipse. What you do find is the 2 extremes, the obesity, blue bloater on one extreme with very low emphysema, high cardiac disease, everything that you associate with being fat, diabetes, renal failure. And on the other end, you find what I call the implosive phenotype, which is low BMI, and they may be coming like that from the beginning. In between, there will be combinations. That's why I dotted those lines between the 2 extremes. If you take the thin person, he's likely to die from aortic aneurysm, atrial fibrillation, lung cancer, and they usually have osteoporosis, cataracts, wrinkles, which is one phenotype that may have a different pathobiology. If you look at biomarkers, they don't have more inflammation. This concept that the inflamed individual is the one that is shrinking is not right. It is the obese person, the one that is inflamed, but has less emphysema. He's able to repair with stem cells that are coming from your fat, I guess, and building up the rest of the body. Not your fat, because you look very good, from my fat. So I think we're opening doors, and this use of high throughput technology will allow us to look at mechanistic pathobiology, which will be a rational way to approach multimorbidity. You know, I always ask the question to the older doctors like me, when was the last time we bled someone for polycythemia from COPD? When I was young, I used to continuously be sent, Celli, go and bleed the guy 1 liter of blood, his crit is 63. And you're going to say, no, it's oxygen. Well, it may not be. It may very well be that the treatment of heart diseases with the ACE inhibitors and whatnot has impacted on the presence and phenotype of those patients that I'm seeing. We still have time for...
Oh, thank you for your fascinating talk. I have 2 questions. One question and thank you. My question, I'm very excited because I've been carrying this question for a very long time. Why did you not put obesity in your original comorbidome picture?
That is a good question. We didn't put in the original comorbidome, we had no clinical characteristic. In the new paper, we've introduced BMI, 6-minute walking distance, age, because when the physician sees a patient, he doesn't have all the other stuff, but he does have BMI. He can do a 6-minute walking distance. You can do an FEV1. You can do an oxygen saturation. So we have 7 clinical variables. And then the clustering becomes more interesting. You know, for example, I don't think the cure for cancer is so much in the monoclonal antibody, the ifimabib, whatever the new product is. It will be the substance abuse personality. It will be the kids at age 18. Why do they take up the smoking if they have the sensitive to the cigarettes? So I think clustering these things helps us. I wish I had another level, you know, biomarkers, metabolomics, so you could then link the clinical with the comorbidome, with the metabolomics, and then make some sense of the association between your clinical presence and your pathobiology. But these are the young guys, like you.
Well, thanks so much. I used to be young, though. My thank you, because it's the first time I see the big ball of microbiome on a slide, and now we keep talking about cytokines and so on and so forth, but now we know that the microbiota from the very beginning conditionate the immunological response, and I think that that is thinking out of the box, to go and check what's going on down there. Thank you.
Plenty to do. I don't know if we have one last one.
Can I? One comment, one question. The comment is that after these two wonderful lectures, it will be difficult to keep up for the rest of the afternoon.
I don't think so.
The question is, in COPD, the most frequent cause of death is cardiovascular diseases. Any suggestion for us who are cardiologists, what is the phenotype you think is important to investigate to this regard?
Well, for atrial fibrillation, aortic aneurysm, it is the thin person. For hyperlipidemia, MI, it is the fat guy. Heart failure, this is the fat person. So we pull all cardiovascular together, they're not together. They're separate. Endothelial injury will be the fatter person. So we think from the organic point of view, all cardiovascular are the same. Well, they're not. And they will express different types of cardiovascular phenotypes on the two sides of COPD that may not be due just to COPD. This thin person who was born thin because the father and the mother and has a certain microbiota will take one path when given an exposure and then expresses disease different than the other person. But we have to prove all of this. All right. Thank you very much.